Hi everyone. I'd like to review Chapter 18, Nutrition as related to renal or kidney disease. I know we went over and reviewed some of the slides in lecture, but I thought it would be a good idea to just complete the whole lecture. So here we go. This is a review, as it should be for A&P. But the kidneys have these microscopic workhorses, and they are called the nephrons. And we'll go into the many functions that the nephrons have as related to nutrition and renal disease. The first one is homeostasis. From a standpoint of blood, so blood plasma, filtering the blood plasma, we want to ensure that there's balance in fluid and electrolytes. And also, as you know, the kidneys function to eliminate wastes, which end up in the urine. So as you can see, as we're going through the functions of the kidneys, if you have acute renal failure or chronic renal failure, as related to nutrition, there's so many things going on and all the functions that could go wrong. The other issue is maintaining acid-base balance, very important. Also, there's a hormone, renin or renin, I've heard both, that functions to regulate blood pressure. So this is also an important function of the kidneys. We also see red blood cell production in kidney function, as well as establishing and regulating calcium and phosphorus mineral balance. And we'll see that's related to vitamin D and the deficiency of cholecalciferol or vitamin D3. Also, you note that maybe in pharm you learned that most medication is metabolized in the liver. However, there are some that are metabolized in the kidney. And so the function of the nephron is to detoxify some of these drugs and also bacteria. So we talked about the blood plasma and the important function of the kidney to filter the blood. Interestingly, it removes more than 200 waste products. And from a metabolic standpoint, there's so many functions from a nutrition standpoint, as we'll see, and also from a hormonal standpoint. So we'll see later that there are certain critical components of the diet that in kidney disease that we have to avoid or limit, and those include protein, some of the minerals, which is potassium and phosphorus, and also fluid as well. So the first set of diseases we're going to go through is nephrotic syndrome. So this is a collection of diseases, and it's specifically the damage to the glomerulus. We see glomerular nephritis and some type of nephropathy due to a secondary disease. So amyloidosis, diabetes, lupus plays a role, and other infectious diseases. So here in glomerular nephritis, we see proteinuria. So we see protein spilling into the urine. We also see hypoalbuminemia, which is a low serum albumin, hyperlipidemia, and the patient is also edematous. So what's very important from a nursing standpoint is we need to monitor body weight and input and output at every single shift, okay? So here in nephrotic syndrome, a patient is losing protein in the urine. That occurs typically with nephrotic syndrome rather with any type of acute or chronic renal disease, okay? That is the difference. Not only will we need to monitor body weight and INOs, but you need to be able to give patient education on food choices that are high in sodium. So what we want to do for nutrition therapy is to control hypertension. So we're looking at low sodium, high calcium, high phosphorus diet. So here, phosphorus is not limited as of yet when we get into acute and chronic. So you see the difference. We want to minimize the edema. We also see that albumin will present in the urine, so we want to decrease those losses by providing adequate dietary protein. We see protein malnutrition, which leads to decrease in lean body mass and also lean body muscle mass. So we have to provide adequate protein as well. And when you're providing adequate protein, you have to provide adequate calories so the protein calories are not catabolized. So this helps slow the progression of the nephrotic syndrome. The focus in terms of nutrition needs for patients with nephrotic syndrome is limiting protein and sodium. So protein, as you can see, pretty congruent to the RDA. We're looking at a range of 0.7 to 1.0 grams per kilogram of body weight per day. Sodium, we want to limit to less than or equal to 2,300 milligrams per day, which that turns out, as we discussed in lecture, to 1 teaspoon of salt per day, which is not a ton. The other issue is to be able to educate patients on hidden sources of sodium. So certain medications provide sodium. They use it as a filler, as a preservative. Also, if you look at toothpaste and mouthwash, especially mouthwash has 2 sources of sodium and some supplies of water as well. So acute renal failure, characterized by the abrupt loss of renal function. We see, typically we see oliguria and anuria. Okay, so oliguria is the low urine output, and anuria is there's no urine output at all. So nutrition education for acute renal failure includes low sodium diet, low protein, low potassium, and usually there's a fluid restriction. And with all those dietary modifications, we typically see constipation, secondary to inactivity, the specific medications they're on, and also the fluid restriction. Again, we're looking at important markers of INOs, daily weight. Typically, you want to weigh the patient at the same time every day if it's possible. And that helps us to determine if they're retaining fluid. There's typically fluid shifts. and if there's protein malnutrition by the loss of lean body mass. Okay, so what's important here for acute renal failure is to determine, is the patient on dialysis or not? If they are not on dialysis in acute renal failure, then we bump down the protein requirement. As you can see, at 0.6 grams per kilogram, but not less than 40 grams per day to prevent malnutrition. In dialysis, if the patient goes on hemodialysis, the components of the blood are circulated through the hemodialysis machine. So what that means is we can give them more protein. And the marker that we recommend is 1.0 to 1.4 grams per kilogram of body weight. So because in the low protein diets, especially when they're not on dialysis, we typically see the B vitamins in terms of deficiencies. So we want to provide actual supplements of thiamine, riboflavin, niacin, and cobalamin, which is vitamin B12. We also see mineral deficiencies in calcium and iron and zinc, typically when the protein levels are low in the diet. There are two phases with regards to acute renal failure. The initial one is oliguric, and then the secondary one is diuretic. So in the oliguric phase, we do need to restrict sodium, potassium, and fluid. Sodium is restricted to 1 to 2 grams per day, potassium 1 gram per day. When you measure fluids, we're restricting the fluids to whatever the patient's output is plus 500 mLs per day. Now, as the patient improves, we move on to what's called the diuretic phase. And as the name implies, typically the patient loses a lot of fluid, so we have to replace the fluids that are lost. Also, sodium potassium is usually lost, so we have to especially monitor serum sodium levels, serum potassium levels during the dialysis phase. Now we move on to chronic kidney disease. So that's irreversible, and it's a progressive loss of kidney function. There's a lot of causes that it can occur. Glomerular nephritis can be advanced to chronic renal failure. Obstructive diseases, diabetes, lupus, and some patients that use illicit drugs end up on hemodialysis. So what happens here in chronic kidney disease is we see nitrogenous wastes are accumulated in the fluid, and we see a lot of different electrolyte imbalances, including sodium and potassium. The goals for end-stage renal disease. So prior to, we want to slow the progression and minimize complications. So that's the tertiary prevention that you learned in that preventative healthcare model. If the patient is in end-stage renal disease, what we want to do is reduce uremia. So they usually have large amounts of urea in their blood, and we can do this through hemodialysis. Peritoneal dialysis is the type of dialysis that's transportable, so sometimes they can do that at home. The other issue we'll talk about is if the patient is on the list for a renal transplant. So let's look at the dietary components of the renal diet for chronic kidney disease. The National Renal Diet was developed by a dietetics practice group, the Renal Group, the Academy, and then also the National Kidney Foundation. So what is important is looking at the restrictions, and the most important critical one is to restrict phosphorus. And that is related, the dietary phosphorus is related to bone health. And let's look at why that occurs. So when you have elevated serum phosphorus levels in the blood, that can lead what's called to osteodystrophy. Osteodystrophy alters the bone structure in patients with chronic kidney disease. So here, there is an important to limit the amount of dietary phosphorus that patients consume in chronic kidney disease. And you know that, you know your high sources of protein. And so you just need to know that food sources that are high in protein are also high in phosphorus. So those phosphorus-rich foods are also protein-rich foods, and you can find those in lean meats, poultry, which is chicken and turkey, fish, dried peas and beans, lentils, and dairy products. Also, the National Renal Diet talks about vegan lifestyle choices, and the renal diet does not accommodate those that are on vegetarian diet lifestyles. So if you're asked a question, what diet choice is not accommodated by the renal diet, the answer is vegan or vegetarianism. So if you're not familiar with hemodialysis, a patient is hooked up to the hemodialysis machine, and their blood is basically, it's kind of like a washing machine. Their blood is removed. There's typically via the vascular access, and their blood is cleaned of fluids and waste products, and it goes through a semi-permeable membrane. So it goes around, and then the fluid, their blood, is returned to the patient's circulation. I mean, it's really a cool machine. Usually takes about 3 to 4 hours, and most of the time we've seen protocol 3, maybe 4 times a week. So if a patient is on a hemodialysis, it's important to correct any deficiencies, prevent the accumulation of the waste products in the fluids, and minimize any of those metabolic effects. So again, we're at the tertiary prevention of that healthcare model. And typically, the diet is determined by what is their loss of kidney function, how often, how often do they receive dialysis, and typically that is the determination that the dietitian makes. Okay, so as we mentioned before, patients that are on hemodialysis will receive a higher level of protein, and then I'm looking at 1.2 grams per kilogram of body weight. We talk about HBV, which is protein sources in the diet that are high biologic value. Well, what does that mean? So HBV are protein sources that are readily absorbable into the blood. They break down very readily. They're presented to the cells, to the tissues to be utilized. Okay, So the best sources are eggs, lean meat, poultry rather, and milk. Okay. Just looking at, I'm not going to test you on the energy requirements, but we usually look at between 30 and 35 grams per kilogram of body weight for calories. Again, let's look at the microminerals to understand this phosphorus and calcium and why we're restricting it. I think it's important. So phosphorus is restricted during hemodialysis. It has that domino effect, which is related to the thyroid. So hyperphosphatemia in the research has shown that that leads to hyperparathyroidism. And then the domino effect is this raises the calcium to phosphorus ratio in the plasma, which is not a good thing, okay? So we have to limit the food sources of phosphorus. Make sure you know that the best sources of phosphorus are milk, milk products, beef liver, chocolate, and legumes. The other thing that is very important here is patients that are on hemodialysis may receive medication with phosphate binders. So it's important for those patients to also limit their sources of dietary phosphorus. The other vitamin that has some metabolic issues is vitamin D. And the reason why vitamin D must be supplemented is because, first of all, it has to be in its active form. But here during chronic kidney disease, the kidneys can't produce calcitrol, okay? Calcitrol is the active form of vitamin D, so we have to supplement it. We usually, during hemodialysis, calcitrol can be administered via IV form during the dialysis process. And the other mineral that is an issue is iron. So we often see iron deficiency anemia in patients on dialysis, and the form that we give them is EPO, which is the recombinant erythropoietin, and that helps to treat iron deficiency anemia. Usually we can give it in IV form, but they do have an oral route for EPO, and that helps again to replenish the iron stores. So there's a lot of nutrition deficiencies, as you can see in chronic renal disease. The other issue we have to talk about are patients that have type 2 diabetes. Those with diabetes receiving hemodialysis have additional nutrition concerns. So the first thing is that the timing of their meals are very important, and they typically require snacks to maintain that glucose homeostasis. The other issue is during hemodialysis, glucose is absorbed into the dialysate. So when glucose is absorbed, their insulin needs will decrease. Okay, so typically we have to adjust the insulin doses. Nurses are typically more familiar with sliding scales, so that'll be a judgment call and an order from the doctor. But just so you know that as a red flag, you cannot provide the same insulin order after hemodialysis. It has to be adjusted because they run the greater probability of experiencing hypoglycemia. Okay, so lastly, let's go through renal calculi. which is also known as kidney stones. And typically they're more common in men than women. And there's different types, but of the kidney disease, in terms of the kidney stones, most are from calcium oxalate. We see 10% making up uric acid, which leads to gout. 9 to 70% is struvite, which I've never counseled on, and then less than 1% is that cystine. So in the typical symptoms that we see with kidney stones, we'll usually see a low urine output. The pH level of the urine is typically elevated. We see excretion of urinary calcium, oxalate, uric acid, or a combination of these three. And when we look at dietary modifications, the first thing is you're going to push fluids. Okay, so the recommendation is increase fluids. When we look at the calcium component of kidney stones, dietary calcium does not need to be restricted. As you can see, it falls between the 1,000 milligrams per day for the RDA. There is a slight restriction of animal protein, less than 1.7 grams. We definitely restrict sodium. But the biggest thing is to restrict dietary oxalic acid or oxalate. There's no rhyme or reason what food products contain oxalate. So I've listed some here, and I also will, on Canvas, I will give you a document for oxalic acid and phytic acid. So you can study for this last exam, the final exam, and ATI. So let's go over dietary oxalic acid. Highest sources are found in spinach, rhubarb, beets, nuts, chocolate, tea, wheat bran, and strawberries. Again, no rhyme or reason. That's just based on the current research. Those patients with calcium stones also need to decrease their alcohol and calcium. We talked about fluid intake and also increasing potassium intake. Uric acid levels that are elevated in the blood can trigger gout symptoms. And those foods that are high in purine can trigger attacks, increase uric acid stones, can increase gout. We find the food sources that have a high level of purine include alcohol, caffeine, organ meats, fried foods, and beef. We also find uric acid levels are elevated by soda, rich cream sources, orange juice, and various fish sources, which include herring, sardines, cod, haddock, and the fatty fish, salmon, tuna, and then anchovies and shellfish. Allopurinol, which you're familiar with, is prescribed to decrease the uric acid levels and decrease the uric acid stones for many patients. And then the cystine stones, they're pretty rare. It's like the 1%. There is a genetic component, and it's important to restrict protein and sodium. So the fluid intake we want to increase. We want output of 3 liters. So if you want to get 3 liters of urine daily, you are required to drink 4 liters of fluid. And it's important because we want to decrease the pH of the urine to 6.5 to 7. And how we do that is to decrease animal protein and sodium.